My pleasure to introduce our next speakers, Dr. Maria Starchook-Moore and Dr. Dominik S Dabrowski. Dr. Starchook-Moore is the Occupational and Environmental Medicine Residency Director in St. Louis Park, Minnesota, with a special interest in the Department of Transportation Physical. Dr. Dabrowski is an attending physician at the Seilikoff Centers for Occupational Health at Mount Sinai Medical Center, bringing clinical expertise from one of the nation's leading occupational health programs. Their presentation today focused on DOT exam quality and challenging cases is based on their published research, retrospective quality review of Department of Transportation commercial drivers' medical examination forms, which appeared in the American Journal of Industrial Medicine. They'll share insights into documentation standards, clinical decision-making, and the complexity of evaluating commercial drivers. Please join me in welcoming Dr. Starchook-Moore and Dr. Dabrowski.
It's been a pleasure. Can you hear me? It's better?
Yeah.
Thank you all for having us. It's a pleasure to be here in DC to be presented. I'm part of CSOMA. Dr. Dabrowski was with me in the residency in the same section. Now he's in MARCOEM as well. So how did this all start? This was my residency project back in the day, the MPH project, where one of my attendings as being the medical director for one of the national companies was complaining about the horrific quality of some of the DOTs that they've seen and how challenging it is to get anything changed when they see that. And we decided, well, instead of anecdotally complaining about it, why don't we do a systematic review and see what's really going on? And so that's kind of what happened, basically. So FMCSA is designed to be a rigorous process. In the recent years, it has gone through some changes. It evaluates the driver's fitness for duty, basically. And we aim to study the quality of these exams that are being performed. And since it's a retrospective review, we only really had the DOT long forms for review available to us. And so this is how we did it. In calendar year 2019, we reviewed all of the DOT exams that came in for a medical director review in that calendar year. It was over 1,600 physicals. And we collected basically all the data points from the DOT forms themselves. And then we created some quality checkpoints that we noticed were more common during the process. So the drivers were employed working for a national company in 8 states. And literature at the time, there really was no systematic quality review of the DOTs at the time. So nothing really to compare to. Okay. Is there a way we can play this video? If not, that's okay, but, so this is just, talks about the challenges of performing DOTs every day and the challenges of collecting the correct information and implementing kind of your actions on this information. Let's just try to play this video, but if we can, that's okay.
Oh, is there audio?
You gotta click on the video, there's a little...
Okay. Oh, is it?
Well, let's start from the beginning if we can, sorry.
Yeah, to there is like a
What makes you come in today? All right, Miss Pillsbury, what's going on?
It's been 5 months that I have this chest pain.
sorry, the audio is not working.
5 months, huh? What makes you come in today?
Well, my
If
daughter
you ever
forced me to come
find
here.
these
Tired of her. Not
influencers on Instagram and find this video, it's very funny, but it basically talks about how completely forgot to make history of heart disease.
Do you have any health conditions?
Cannabis use, substance use.
Do you take any meds?
And how challenging it is to pull information.
I see metoprolol, amlodipine. You have history of heart failure and 2 open heart surgeries. Does that sound correct? All right, Miss.
No. All right. So, wait a second. So, some things we collected from the DOT form. So, examiner state, examiner licensure, and national registry number. This was more collected for subsequent quality control measures. Say if we found examiners that we disagree with more often than not, then maybe they could potentially be taken off the list of examiners for the company. We didn't implement it on a large scale, but that information is available for review. Driver health information that we collected, so age, gender, surgery history, medication history, health history, those on page 2, those items 1 through 32 that we're familiar with, other health conditions, height, weight, and basically all of the physical testing. Okay, so, and then we created some measures to basically evaluate the quality of the examination. So, did the examiner, so this would have been nice to pull up a DOT long form side by side to kind of walk over. But if you can imagine, the first page would have history of medications, history of surgeries. Second page would have the health conditions that they basically check mark yes or no 1 through 32, and then other health conditions. And there at the bottom, there's this little box for medical examiner to describe what we're talking about. So that's the one at the top. Did the medical examiner comment on the driver health history at all? Did they complete all the required testing? If there was an abnormal physical exam, did they comment on it? Whether they filled out the federal state form, intrastate form, or both. Whether they described why they gave a limited certification to the driver, whether they created a homemade form rather than using the FMCSA form, and we had one group that exclusively was performing physicals on a homemade form, which is not allowed. Whether an exemption was noted on the form, so we found some of them that weren't necessarily noted, and then so we had some idiosyncratic errors that were made on the forms that were hard to classify. So we just used the critical judgment of the reviewer whether we thought that the FNCSA form was completed correctly overall. So, and these are some of the results we got. So this is what the driver population looked like: predominantly male, predominantly 30 to 59. We can see how heavy they are, and that has to do with, there's another table here that has to do with increasing comorbidities with increasing specific weight categories. And I'm going to do this table first. So again, if we imagine the page 2 on the long form, where we check mark specific health history elements. So this is what we got. This is how many driver mark that they have a specific health condition, whether they marked no, whether they marked yes, whether they marked not sure, whether they left it blank. So there's 2 columns there that's one is missed and one is omitted. Omitted is where the driver left the column blank, but then the medical examiner actually asked them questions and turned out that they did in fact have that condition. And then missed is nothing was marked and we don't know if they had or didn't have it. So that was left blank. And the last column there, if you see medical examiner comments, so that's again kind of the money column, is you can see how many of these conditions were noted by the drivers and how many cases the medical examiner said something in their specific box where they're supposed to comment on their history, and how many of these they didn't. And this is actually quite alarming because we can see that about 20% of the time, even when there are sleep apnea, diabetes, heart disease, a myriad of chronic conditions, the medical examiners still don't comment anything about kind of what's going on with that health problem. So, this is another one of the tables. If you can imagine the long form in front of you. This is basically a correlation of what the text says in the text box and whether their comment was. So basically, did you mark yes or no in front of the box, whether you have a condition, and then whether you described something below it correctly. And overall consistency about 40% on that one. And then, so again, this is one of some of the other quality checkpoints that we created. So no medical examiner review on positive medical history, so 19%. I would say that that is one of the biggest findings. So the genie in a bottle came out and said, what's the most important thing that you can do on a DOT? I would say it's this: comment on driver's medical history. And if like 20% of the time, if they said they have something and you didn't write something down, that's, I would say, a problem. So physical testing almost always completed. Something was missed in 20 cases out of 1,600. No elaborate, only 2 people didn't write something down if they marked something was abnormal on physical exam. So another one, but that was a specific group where their physicians always filled out both federal and state certification form. We kind of communicated to them repeatedly that they only need to pick one. Limited certification without specifying why they did it. Non-standard certification, again, that was one specific practice group that basically wrote down the elements of the DOT long form in their EPIC template, and they were just completing their physicals in the EPIC template just because they didn't have an additional EMR or they didn't want to deal with the paper forms. They were actually pretty reluctant to us telling them that this is not legally acceptable, that it has to be the federal form. And so, waiver error exemption, again, that was if a waiver wasn't marked when it was appropriate. Overall, if the form was completed correctly. So, unclassifiable minor issues, otherwise it's about 2%. So any error by the, so we have 2 areas of error. So we have medical examiner error. So we said about 30%, and then we had driver errors on the prior slide, which was, we said about 38%. And so, basically, so DOTs are a rigorous, complex process. So there are multiple goals to this process, and one of them is to identify issues. A lot of the drivers never go to their doctor. They feel like they're fairly healthy, even in varying age groups. So DOT physical is an important checkpoint that they might not have otherwise. So you might identify these issues and refer them to get them treated that might not otherwise get picked up. So I would say attention to detail and kind of follow through is very important on this. And then we're identifying risks, basically through periodic examinations, and then we're also identifying risks to them and the public. Again, that's that scale that we talk about. So financial impact, so the cost of chronic disease, so chronic importance of cost of chronic disease both to the driver, to the society, to the company. If we're able to manage their chronic diseases better, that decreased cost overall. And then lifestyle challenges. Drivers are a very unique population that they, especially long-haul drivers, they might not be able to get their care as often. They are constantly on the road. They might not be able to park their truck in a clinic parking lot. So that's something that we should take into consideration, and that's where we can have a unique opportunity maybe to create wellness programs that are targeted for them, and we may have potential options to implement those programs. And then this was the length of certification that we got overall for this cohort. And then this is kind of the main, one of the bigger slides is if we identified that the drivers complete errors and make errors in completing their form about 38% of the time. With medical examiners, erroneously complete the long forms about 30% of the time. And in about 13.5%, both of them made errors in completing the form. Like, what are we doing here? Should we improve the form? Should we improve the process? Should we make it more transparent or easier to understand to both drivers and medical examiners on what we're doing here? And so that kind of is the challenge that we have. And there, like I said, there hasn't been really a quality review like this before this. So if anybody wants to review their DOTs, I highly encourage you to do that. And yes, I'll pass on the baton to Dr. Dabrowski here.
Hello, everybody. All right, so what can we draw conclusion-wise from all this? Where do we want to go from there? Well, the reason why we think this quality control is important is not only because it hasn't been done all that much, but also because there are a lot of opportunities to address health issues within that. So, better healthcare for the driver, sure. It's easy to bring them in, list of conditions that they may or may not have. Okay, you're qualified or you're not, but should that really be our only role? I understand that there are reasons why it should be and reasons why it shouldn't be, but as far as holistically looking at the driver, how can we help them be healthier and therefore more confident at work, healthier, happier, and then of course the downstream public health impacts that we could hopefully prevent as well. We have a missed opportunity also to address the higher risk of the driver while they're driving. What could they be doing while they're in the route of work that can lead to injury, that can lead to illness, that will lead to restrictions down the road? And of course, from the public health aspect, how are we preventing those motor vehicle accidents, which can be extremely costly, not only to life and limb, but also financially. It can shut down roadways, it can cripple the local area for days or weeks until the necessary repairs are made. We want to cut those things off early. We don't want them to ever happen, is essentially the point. We do want to talk a little bit about what we did and what we could have done differently and what maybe future research could pick up where we were unable to. So this was a manual data extraction, collection, analysis, which can get the job done. Human power is wonderful, but if we could incorporate some sort of informatics, some higher level computing, and one of the authors on our paper even says that he's a bit of an informatics guru, and he says if he could go back in time and do everything the same but change one thing, it would be to put all this data into some high-scale algorithm to be able to find maybe more trends, future directions of research, etc. We also had limited availability for crash data since this was a cross-sectional study on their health just in the medical examiner's office, so we don't necessarily know what happens downstream. And again, as I alluded to, cost analysis is important. Is this actually saving money? If so, is it in the healthcare field, in the public damages field, etc.? And then this was, I think we can tell them the company, right? So it's Xcel Energy, based out of St. Paul, Minnesota. A large company covering 8 states, as we said. We'd like to think it's generalizable, that we could apply it to other parts of the country, but we don't actually know that. So could the Northeast, like MARCOEM, be different? Could DCOM's area be a little bit different? Perhaps. So we don't actually know that either. And so, again, what can we draw from this study? What are the most important parts? There's a lot of different ways to do these CDL exams, as we saw. Perhaps some more uniformity would be helpful, but that might be asking for a lot. What's important is to, again, if we could change one thing, is make sure those elaborations get written out, because that can be the difference between, oh yeah, I had a few quick heartbeats one time 5 months ago versus I have AFib. That's a significant difference. So we always want to chase our drivers a little bit, especially if they check yes on something. The divergence was 55% overall. That's huge. We really can't have that happen long-term everywhere. That's a problem. And then we want to make continued efforts needed to enforce and encourage adherence to best practice guidelines. Now, I know that sometimes the regulations are a little bit sparse, and I will talk about that as we get into the cases in a couple of slides, but there definitely is room for best practices, and we need to, as a community, discuss that a little bit more as opposition. So we're going to get to our first case. The first three cases are real cases. We will tell you what happened after we get your input. And then the last case is sort of an idealized hypothetical, just to touch on some other things that we think are important. So here we have a 57-year-old male. He has a remote history of liver transplant. It's been well managed, no current or past complications. Immunosuppressants gets followed up every 6 months. Has a BMI of 40. He is pre-diabetic and not on medications. We were not forward thinking enough to get a Slido going for this, but we would like to get some input either by a raise of hands or a shout out, whatever you folks want to do. How long would you certify this person for, and regardless, would you recommend any interventions? Do we have any anybody who's willing?
Yes, no, he's normal. Blood pressure is good, A1C is good, liver transplant 3 years ago on immune suppression, so he's stable.
You have the evaluation.
No, but would you?
Yeah.
Absolutely.
And we'll talk about that on the next slide.
Okay.
What were twins?
3 years.
Was that what caused it? Why did he?
How long would you certify for, and would you recommend any intervention?
So actually, it was not noted on the long form when he had a liver transplant. I don't think it was helpful, so I can't answer that.
Yeah, that was.
Nothing was mentioned about alcohol. I'm not going to make it so much.
That's something that should be important. We should find an underlying reason why it's not.
And that's what we were preaching previously. It can be frustrating when they do not elaborate.
Would you guys like to know what the examiner did in this case?
Yes.
They have a 2-year card with no interventions. So this was actually one, so I didn't really review these DOTs for this company, and I communicated to the medical examiner that he should get a 3-month card, he should get a sleep apnea evaluation, maybe like a little bit more, and the memo provider says that they did not feel like that was warranted.
Was and of course no update from whoever is following him for his post-transplant care, right? Because that would be the other thing to change.
So again, this was done under a model of medical examiner and then medical director reviewing. So that's why there might be some conflict. What ended up happening was he got a 1-year certification, and then a lot of the things that were mentioned by the audience were requested.
Yeah, so we did get them to change it to 1 year, but they no sleep study, no nothing.
But let's touch on that a little bit. So here we have a little bit of an outline. We want to focus on the BMI, which was relatively high. It was in the morbidly obese category. So we do want to just touch on what some of these different tests would be. Of course, the sleep study is at the very top of what we would recommend. Of course, we would also recommend weight loss. However, that stops being in our purview entirely. That may be is early or is not. We can debate that. But then just want to show you a few pictures of those swollen tongues just to see how bad the obstructive sleep episodes can be. And most of those criteria under the second category under B, those are essentially stop bang symptoms and a few other things.
Yeah, and this guidance document I found to be very helpful. I often could share that with either patients or other practitioners, and basically that goes under conditional certification if your BMI is 40, so you definitely qualify for a sleep study referral with the shorter card. And if your BMI is 35 with some other health conditions, age of 42, blood pressure, diabetes, things like that, then you would also qualify for a sleep study referral. So that's kind of how we routinely practice in the clinic, but unfortunately I don't see that practice as often in the community. That's something that I do share with the medical examiners across the country, but they're pretty resistant. I think partially because there's less and less regulatory support, but that's a little bit of a different story. But at the end of the day, the best science, the best medical guidance has not changed. So even it's DOTs are always an adversarial situation. It can be hard to limit somebody. It can be hard to tell them that you either need a shorter card or you need other things done. So it's always hard for the medical examiner to be in an adversarial situation. And they usually typically try to fall back on regulatory support, which now they have less of it. But I would say that even though that's happening, the science hasn't changed. And if there's ever an investigation, if there's ever a crash, a fatality, or other investigation, the best science would always be followed. And this is a fairly small specialty, and a lot of our friends are the medical expert witnesses in these cases, and just talking to them, we can say that always the best practice guidance is what's referred to in court in these cases where it's not followed, they're basically indefensible. So I would encourage examiners to try to stand their ground whenever they can.
Yes, sir.
One thing I tell the providers, the doctors that are managing these patients, I said, I need that evidence to show that the person's clear. What do you mean evidence? I go, evidence, so when we go to court, I have some documents. What do you mean? So if something happens, no one cares. When you go to court, you better have your ducks in the water. Now, I've been doing FA exams, and we were talking about that. They're very detailed in what they require. And unfortunately, DOT, to do the 2044 guidelines are terrible. I mean, 20 years ago, they had better guidelines. With the very detail on how you do this. We're just talking to Julia, and that, yeah, they actually removed this. That was one of the things for sleep apnea, they used to have this, and then DOT removed it. So we're kind of like on our own. We have to rely on the providers to give us that. Like this guy, I wouldn't have cleared him unless I had, sleep apnea or have some documents, whether they're treating physicians say he's done it. And one of the things about sleep apnea, which I'll tell everybody, the only person that's truly able to evaluate sleep apnea is a board certified sleep specialist. So you get it from anybody else, you might as well just throw it in the garbage. So, I try to avoid.
Yes. The other comment I must make is, even though they like to say what they say, the employer, if it's a national trucking company, may want a higher standard of care. So it still helps to know who you're doing the exam for. And those of you who do a lot of DOT exams, I do not do them anymore by choice, believe me. It really does help to know who your customer is and if they have internal guidelines.
Yes, that's a very good point. And I've worked with different companies, worked with a local transportation company, that they enforce the highest standard of DOT quality. They would only allow one practice in town to do it. They would not allow them to go anywhere else, and the drivers would have parked from somewhere else. They would have them get evaluated. And I used to be part of that group, and I would see going people that have cars that shouldn't have gotten them. There's a capture mechanism for these guys. I would say they were medium. They want some quality, they want quality control, but they're also union based, and they also have some dynamics with the legal department and the union. That quality, there's somewhat limited in what they can do, so I would say they're medium. You have to look at you kind of have to look at it also from the perspective of how much information is there at any one given time to totally disqualify or to give them a provisional clearance, let's say, on a very tight leash, so that the additional information can be developed, and whether or not a permanent restriction or restrictions, again, that require the organization to engage in an accommodation process. So that's the employer side of it versus what you see on the medical side. So that's the other thing you have to keep in mind when it goes to legal, for instance, and HR for that matter.
So I have a question for you there.
I just wanted to say that, like, if you're doing multiple exams and you have other things to do, a lot of these, the medical centers, corporations, they want you to do it really quick, even if the person is, has a million things wrong with them, so you can get the revenue.
Yeah, I decided that to be selfish in those circumstances. One of my senior partners, when I just started, because I was complaining about that particular thing, and he said, well, if you don't make now, you're going to have to make time to explain yourself to the Board of Medical Practice. So I figured, so I'd rather make time at the time of the exam and make it when it back out. Some time will happen.
I agree, as the board getting pushed for the certification.
And then also another downside to that is organizations that are based on patient satisfaction scores. So that's another one that is followed by your DOT staff. So
Yeah. Just in the interest of time, we're going to move along to our next place. This is a 38-year-old male, has a history of depression and anxiety that are well controlled. Previously long-standing Seilikoff, recently prescribed Klonopin. And question is, how long would you certify them for? What questions do you have, and what interventions might you recommend?
When we got a clearance in first position, seems like he has to be suicide.
Good question.
What was the question?
Same as before. Like the certification, and would you recommend the intervention?
I mean, what were you responding to just now? Sorry.
He was saying, is there a history of suicidality?
basically get the information from the treating physician. Do they have history of suicide? Are they well controlled? So, yes, very good.
What I've been told is that they have an active card, so let's say their personal experience for a month or so as you're doing this exam now. If you even give them a determination pending, you're validating their current card. So until you have further information, I've been instructed to temporarily disqualify them until they're able to come back with presenting information. Otherwise, they're leaving, they're getting back into the vehicle. If you've given them somewhat like a provisional card, your name is attached to that exam that day. So in this case, until I have that information from their treating provider on the Klonopin, I would DQ.
And I think that would have been great if they had done that. Unfortunately, that is not what happened. This medical examiner recommended a 1 year certification.
They didn't request any information immediately. All right, and so on the next slide, we can see kind of what I recommended. So I was supposed to in residency to stop give class to people on opioids and benzodiazepines. I did communicate to the medical examiner that they should give them a card of Klonopin, or alternatively request information from the doctor that they should probably come up with Klonopin and do some sort of implementation. The medical examiner disagreed with me. They refused to change anything. And in this case, we actually did have a company pull the driver off the road and we did the process of coming up.
And just as a little bit of bonus material, because addiction medicine is the can of worms I like to drink over. The way that benzodiazepine tapering is done, if you will, is the most common method is known as the Actin method, which essentially means you take them, you replace their high potency benzodiazepine with a lower dose one that has larger numbers for the dosing. That way you can incrementally decrease that dosage by less, if you will. So, for example, with Klonopin, which comes in 0.5, 1, 2 milligrams, that sort of thing, you might transition them to something like diazepam, which is approximately 20 times larger doses. So you can get them up to, let's say, 20 and bring it down every week, 2 milligrams, 5 milligrams, depending on the situation. That's sort of how that goes. And this is a long process. So in the case of a DOT exam, if you are temporarily disqualifying them, you should not expect them back for months, basically, just because that's how long this process takes. It can be 3, 6 months or longer, sometimes depending on the agents.
And I did, in my practice, I did it several times. I did see drivers on Klonopin. I did communicate that they shouldn't be driving on it, and they were able, usually it was for anxiety, and they were able to transition into something else, and they did end up getting a car 1 to 3 months down the line. Sometimes shorter if they weren't actually using the Klonopin. So I did see some patients, for example, they had version, they would take it once in a while, but not really regularly. So they're able to come off quicker. Those that are visually they come off longer. So it's doable. It's doable.
And that's going to bring us to our next case. This is a 42-year-old male, history of diabetes mellitus and hypertension. Both are well controlled on medicine, BMI of 38. And again, what would your length of certification be, and would you recommend anything? Very good. Yeah, that was sort of the main point of this one. We just wanted to bring it back to sleep apnea because it is so important, and the number is slightly lower in this case, 40 versus 38, but we're still above that threshold of 35, so this is not a skinny individual. They still very much need it. I'm sorry?
They have risk factors with their diabetes.
Absolutely.
And again, they got a 1-year drug without referral, and then with no interventions recommended by the medical examiner. We're trying right now. We're trying to figure out with the company what their risk tolerance is and how many of these they want to pursue and actually pull off the road. We decided that the high risk ones they definitely want to pursue. And one of the things that now would be that kind of be in this category is, so now we're just trying to decide with the company what is their threshold. Do they want to pursue these and get these exams up to speed, or are they going to do something more certain? Really challenge there.
All right, and that will bring us to our last case. Oh, sorry, I thought that was a question. So again, substance use disorder, not substance use, is a passion of mine, and so I just wanted to touch on this case. This is the more hypothetical case, but it's something that comes up often, and this is something that in the last few months has gotten some public discourse within ACOM, so I wanted to touch on that. We have a 37-year-old male, hypertension controlled with the lowest dose of hydrochlorothiazide. This person was a 1 bag a day of heroin user 5+ years ago, but has since that time joined NA and has even become a sponsor and is taking buprenorphine. That is their norbuprenorphine to buprenorphine ratio, 4.7 to 1, which means that it is well controlled, that he is in fact taking it. What would you recommend for length of certification and or intervention? Yeah, okay. Was that all I heard, or was there something else? Zero. Okay. Yeah, and that is definitely a school of thought that I would touch on because fair enough, there are good and bad reasons for any length of certification in this case. So this is actually from the Open Forum. I don't know if those of you who follow the Open Forum, this came out about half a year ago, May, June. A person asked a question about how should you certify for buprenorphine administration. Officially, the practice safety guidelines recommend acute or chronic opioid use is not recommended for patients who perform safety-sensitive jobs. These jobs include operating motor vehicles, other modes of transportation such as forklift driving, overhead crane operation, heavy equipment operation, sharp work using knives, box cutters, and needles, work with injury risks such as heights, and tasks involving high levels of cognitive function and judgment. This is a C rating, so ACOM considers this a moderate recommendation, and then this is just a link to some more discussion on that. But then on the Open Forum, these are some of the comments that people gave, and they run the gamut a little bit, so there's plenty of ways to skin a cat, and this is sort of what some people recommend.
But what
things such as random drug tests or ongoing therapy. Case by case is probably the wisest way of doing things. Saying yes or no prematurely may be problematic. Recommending printouts from pharmacy prescriptions. Apparently there was some doctor shopping with one person's experience, so that's important as well. And then recommending a letter from the treating physician that they will not change the dose over the course of the certification. So whether that's 1 year, 3 months, 2 years, etc. Maybe less commonly taken around, but
I think that's more than okay. That might be a good idea.
well.
And then some more comment from the
It's me? I don't think it's me.
So going back to those guidelines from a little earlier, again, I promised the last time I'm just going to read words off the slide, but many researchers who have reviewed the literature have concluded that there is no increased risk of motor vehicle crash with chronic opioid use. They're, of course, referring to stable doses, not changing, not acute. The American Pain Society said, in the absence of signs and symptoms of impairment, there is no evidence that the patient maintained on a stable dose of chronic opioid therapy should be restricted from driving. Now, this is, first of all, these are different opinions from different societies. Second of all, these are talking about an opioid dose specifically, so that skirts away a little bit from the question of opioid treatment, so your methadone and your buprenorphine. However, it is related and deserves to be at least discussed in a forum like this. And then there was found to have increased risks of crashes with codeine and tramadol, which is a partial opioid to tramadol. Reversal of risk during opioid cessation is a concern. And then, of course, when people have substance use disorder, they don't tend to have monosubstance use disorder. There tends to be other substances as well. So asking about even over-the-counter things like antihistamines is a good idea. Okay. So, and so basically to conclude on that, there was a study that came out of France in 2012 that looked specifically at whether truck drivers between 2005 and 2008 who had methadone and or buprenorphine in their systems were more likely to crash. They found that in 196 patients who were examined, there was use of methadone and buprenorphine, but it was complicated by the fact that virtually all of those patients also had alcohol in their systems and also had other things such as benzos in their systems. So it's still very much a gray area, and I'm sure there's a few different opinions in the room on how long you would have certified the patient previously. I'm intentionally leaving a little bit open-ended because best practices don't really exist yet, not definitively like that, no true guidelines. Some combination of the Hartenbaum rule, which is when the regulations fail, use your clinical judgment, and harm reduction, which is in the context of substance use. You want to do every little thing along the way to make that substance use less likely to harm. And now for some people that can mean disqualifying, and that's fair. That's I don't want to comment definitively on that, but those are just some things to think about. So I would just like to say thank you for listening to our talk, and we are open to general questions now.
I'm curious, since you published, has anyone from FMCSA gotten in touch with you or out to FMCSA?
No.
I was the chair of the ACON president committee.
Yeah, I would
quality.
Yeah,
I reached
love
out
to.
to Joe Sentat, passed away, so we never had a chance to talk. But there's a new chief medical officer, James Hill, and I reached out to him. And,
yeah, I would love to talk to them. And actually, another thing that we're doing, so since this all happened, we did this, 5-6 years ago, it was all on paper now. I'm actually doing these reviews as the director for the same company. And now it's all digitized, and now it'll be way easier to pull this information and see if it changed. So, especially with the AI and everything being original, so we're thinking about doing a sequel to this.
That's fascinating study. Michael Hobson, formerly OSHA. He actually got involved with MSHA, with a death in a trucker who drove off the road and into a pit and was submerged for over 2 hours. He hadn't drowned. We tried to get the last exam from the Department of Transportation because he had a CDL, and they wouldn't release it. Has anybody gone back from the first case? There was the implication that these people can die, cause trouble. Has anybody gone back and looked at the failures of exams to identify, likely causes?
No, we don't have crash data. So that's
because they have a national registry. They have a registry of all deaths happening.
Is that for the FMCSA?
Yeah.
I think we could probably actually, if it's from the FMCSA, we could pull it and correlate it. So one of the things that we wanted to do is we wanted to correlate with crash data, and it's a little harder to get it in the company because they're a little resistant with their legal department and such. So, but if we can get it from the FMCSA, I think we would love to do that. Yeah, and actually, funny you say that there was just a fatality in the Twin Cities where a truck driver that was on oxygen became dizzy, passed out, and drove on the side of the road and killed a bystander that was parked on the side of the road. You know, that was actually just exactly, yeah. Yeah, I believe oxygen is installed there, so that's, yeah.
Well, thanks very much for a very, very interesting presentation. We'll move on to our speaker.